This is the Missouri Cancer Registry's required site-specific data items for prostate and colorectal cancers. My name is Babette Langenecker, and I will be the presenter for this topic. I would like to thank Jennifer Sudovic for creating the slides for this presentation. Let me take a moment to acknowledge the source of our support for making this presentation available. The Missouri Cancer Registry and Research Center is supported in part by a cooperative agreement between the Centers for Disease Control and Prevention and the Missouri Department of Health and Senior Services, and a surveillance contract between DHSS and the University of Missouri. Our agenda for today will be the following site-specific data items: prostate Gleason score clinical, prostate Gleason score pathological, prostate PSA lab value, and colorectal microsatellite instability. Prostate Gleason score clinical. Prostate cancers are graded using prostate's Gleason score or pattern. The pathologist determines the Gleason patterns by looking at the prostate tissue under the microscope. The pathologist assigns a grade to the pattern occupying greater than 50% of the tissue. This is the primary pattern and is indicated by the first number of the Gleason grade. The second number is the secondary pattern and is the second most common pattern seen. These two numbers are added together to create a pattern score, ranging from 2 to 10. The prostate Gleason score clinical data item records the Gleason score based on adding the values of the primary and secondary patterns in the needle core biopsy or TURP. If you have no other information, a physician's statement of Gleason score clinical can be used. You always want to code this data item before neoadjuvant treatment. Sometimes only one number is given instead of the two pattern numbers. If only one number is given and it's less than or equal to 5, code the total score to X9, unknown. If only one number is given and it's greater than 5, assume that is a score and code as stated. Sometimes the pathology report specifies a number out of a total of 10. The first number given should be the score. For example, the pathology report says Gleason's 8/10. The Gleason score would be 0.8. If there are two numbers, assume that they refer to two patterns, the first number being the primary pattern and the second number the secondary pattern. Add them together to obtain the Gleason score. If different scores are documented on multiple needle core biopsies, code the highest score. If needle core biopsy and TURP are both performed, code the highest score. Do not infer the Gleason score from grade group, code X9, unknown. This is the prostate Gleason score clinical code table. As you can see, you have Gleason scores from 0 to 10. Then you have X7, no needle core biopsy or TURP performed. X8, not applicable. X9, not documented in the medical record. Or Gleason score clinical, not assessed or unknown. Prostate Gleason score pathological records the Gleason score based on the values of the primary and secondary patterns from prostatectomy or autopsy. Do not include patterns from tissues taken prior to prostatectomy. Prostate cancers are graded using Gleason score or pattern. The pathologist determines the Gleason patterns by looking at the prostate tissue under the microscope. The pathologist assigns a grade to the pattern occupying greater than 50% of the tissue, This is the primary pattern and is indicated by the first number of the Gleason grade. The second number is the secondary pattern and is the second most common pattern seen. These two numbers are added together to create a pattern score, ranging from 2 to 10. The prostate Gleason score pathological data item records the Gleason score based on adding the values for primary and secondary patterns from the prostatectomy. If neoadjuvant therapy is given, code Gleason pathological score to X9, unknown. Do not infer the Gleason score from grade group, code to X9. If you have no other information, a physician's statement of Gleason score pathological can be used. Sometimes only one number is given instead of the two pattern numbers. If only one number is given and it's less than or equal to 5, code the total score to X9, unknown. If only one number is given and it's greater than 5, assume that is the score and code as stated. If the pathology report specifies a specific number out of a total of 10, the first number given is the score. For example, 6/10. The Gleason score would be 6 and coded as 06. If there are two numbers, assume that they refer to two patterns, the first number being the primary pattern and the second number the secondary pattern. Sum them together to obtain a score. Do not infer the Gleason score from grade group, code X9, unknown. This is the prostate Gleason score pathological code table. As you can see, you have Gleason scores from 02 to 10. Then you have X7, no prostatectomy done. X8, not applicable. X9, not documented in the medical record. Or Gleason score pathological, not assessed, or unknown if assessed. Prostate PSA, prostatic specific antigen lab value. PSA is a protein produced by cells of the prostate gland and is elevated in patients with prostate cancer. This data item is required for prognostic stage grouping in AJCC 8th edition. Serum PSA is not the same as free PSA or precursor PSA. Do not record values from either of these tests in this field. Serum PSA is the most sensitive tumor marker for monitoring individuals with prostate cancer. Although originally not intended to be a screening test, this simple blood test has become a very common method of detecting new prostate cancer in its earliest stages. PSA can be negative when prostate cancer is found on digital rectal exam. In such cases, PSA will not be helpful in monitoring for reoccurrence. PSA is a prognostic factor required for AJCC staging. It affects the stage group in most cases. Lab values must be obtained prior to any treatment, including surgery. Record to the nearest tenth in nanograms per milliliter. Record the last pre-diagnosis PSA prior to diagnostic biopsy of the prostate and initiation of treatment. Use the most recent value if taken within 3 months before diagnosis. For example, a patient has an elevated PSA, but doesn't return for biopsy until 6 months later. The PSA would be unknown. The general instructions for lab values instructs registrars to use test results from approximately 3 months or less before diagnosis. Physician's statement of PSA pre-diagnosis can be used to code this data item, when no other information is available. If an adjusted PSA value is documented by a physician in the medical record, record the adjusted value. Do not adjust the PSA value based on BPH medication use. Enter the value documented by the physician. A discrepancy between the PSA documented in the lab report and the PSA documented by the physician may arise due to the physicians adjusting the PSA. Certain medications for benign prostatic hypertrophy, BPH, decreases the PSA. The fact that an adjusted PSA value is being recorded should be documented in the diagnostic procedure lab tests text field. This is the prostate PSA lab value code table. Record values to the nearest tenth. If PSA is 1,000 or greater, code XXX.1. If test is not ordered, code XXX.7. And if PSA is not documented in the medical record, or a PSA lab value is not assessed or unknown if assessed, code XXX.9. Colorectal microsatellite instability, or MSI. The test for microsatellite instability for colorectal cancer describes cancer cells that have a greater than normal number of genetic markers called microsatellites. DNA mismatch repair, MMR, is a system for repairing DNA. Microsatellites are sections in our DNA with repeat sequences. Microsatellite instability is when cancer cells have a higher than normal number of these microsatellites. The presence of microsatellite instability may indicate that the mismatch repair genes are not working correctly. Mismatch repair genes, MMR, work like genetic spell checkers by correcting errors in DNA as cells divide. The MMR genes identify these genetic errors and destroy the sections that are bad. They also prompt other genes to come along and add the correct sequence. When MMR genes stop functioning, areas of DNA could start to become unstable due to these errors. A MSI or screening test looks for changes in DNA sequence between normal tissue and tumor and can identify whether or not there is a high amount of instability, which is called MSIH, or if there is a low amount of microsatellite instability, called MSIL, or if the MSI is stable. MSI is found in about 15% of colorectal tumors. Some patients with a MSIH may have Lynch syndrome, though many MSI high tumors are sporadic. Patients with high MSI should be tested for hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. These patients have a poor response to 5-FU, though they may respond well to targeted immunotherapy. Testing for MSI may be done by immunology or genetic testing. Immunology can test for the mismatch repair, MMR protein. MMR intact, no loss of nuclear expression, use code 0. MMRD, loss of nuclear expression, or MMR protein deficient, use code 2. Only genetic testing can tell if MSI is low or high. Unstable low, MSIL, use code 1. MSI high or unstable high, use code 2. Mismatch repair, MMR, is being used more frequently in the U.S., historically used primarily in Canada. If both MMR and MSI are done, and if either test is positive, use code 2. The following statement is not enough to code MSI positive. Low probability of microsatellite instability high. If the only documentation for MSI is stated as low probability of MSIH, consider the tumor MSI stable and use code 0. The MLH1 gene provides instructions for making a protein that plays an essential role in DNA repair. This protein helps fix errors that are made when DNA is copied in preparation for cell division. The MLH1 protein joins with another protein called PMS2, produced from PMS2 gene, to form a protein complex. This complex coordinates the activities of other proteins that repair errors made during DNA replication. The repairs are made by removing a section of DNA that contains errors and replacing the section with a corrected DNA sequence. The MLH1 gene is a member of a set of genes known as the mismatch repair, MMR genes. And there's a very simple video that explains the MMR process, and it's on the web address listed on the slide. The video gives an example of when the MMR process is working correctly. And what we're trying to identify in code 2 is when the MMR process is not working correctly. This is the microsatellite instability code table. Underlined in red are the terms you should be looking for when you're coding microsatellite instability. This is a list of the sources used in this presentation. If you have any questions, we can be reached at our toll-free 1-800 number. Thank you for viewing this YouTube presentation.